Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning everyone. Welcome to Meta Journal Hour 21 series. I'm Nur Faiza Saibul, Research Officer from Clinical Research Unit HSAAS to UPM. Okay, today we will discuss another interesting journal article entitled Prevention of Non-Ventilator Associated Hospital Acquired Pneumonia in Switzerland, a Type 2 Hybrid Effectiveness Implementation Trial. Okay, this article was recently published in July 2023 in the Lancet Infectious Diseases. Okay, you can scan the QR code here to access the full article. Okay, before we proceed with the article, I would like to thank everyone for joining us today. I hope this session will provide knowledge and insight on how to conduct high quality research, particularly on type 2 hybrid effectiveness implementation trial in the future. I would really appreciate if you all could share your knowledge, ideas or opinions on our discussion today. Feel free to interrupt or leave your questions or comments in the chat box. Okay, let's start with the introduction. Okay, hospital-acquired pneumonia or HAP contributes the highest number of disability-adjusted life years among 6 major healthcare-associated infections. About 60 to 70% of the cases are non-ventilator-associated hospital-acquired pneumonia or NV-HAP. Around 50% of the patients with NV-HAP require intensive care unit admission. 20% need mechanical ventilation. Many have a long hospital stay, and 30% have a fatal in-hospital outcome. Okay, now we will look at the rationale of the study. Why should this trial be conducted? Okay, available guidelines and scientific literature on nosocomial pneumonia prevention focus primarily on ventilator-associated pneumonia or VAP. Limited evidence on the effectiveness of prevention bundles compared to single preventive measures. The current study investigates the effectiveness of an intervention to introduce a 5-measure NV-HAP prevention bundle using a multifaceted implementation strategy in a broad surgical and medical patient population. The hybrid type 2 trials simultaneously evaluated implementation and effectiveness outcomes. The findings are not only on the effectiveness of the prevention intervention in lowering the NV-HAP incident rate, but also it reveals how the key determinants influence the implementation of the NV-HAP bundle. Okay, in the research context, the primary purpose of a hybrid design is to speed the translation of research evidence into routine practice by conducting aspects of effectiveness research alongside implementation research. Okay, now we look at the definition of effectiveness and implementation research. Okay, effectiveness research is conducted to evaluate interventions. Meanwhile, the implementation used to test strategies for delivering the intervention. Okay, the combination of a combination of effectiveness and implementation research is so-called a hybrid approach. Is used to simultaneous a combination of effectiveness and implementation research is so-called a hybrid approach. Produce simultaneous results on the effectiveness of the intervention and its implementation, and to provide understanding and to facilitate replication and scale up of a new intervention more broadly and rapidly. Okay, for the current study, this type 2 hybrid effectiveness implementation study was conducted with the aim to evaluate the effect of a prevention intervention and multifaceted implementation strategy on NV-HAP incident rates and implementation outcomes. Okay, now let's look at the method of the study. Okay, this study is a type 2 hybrid effectiveness implementation trial with a quasi-experimental, non-randomized and step wedge design. Okay, the single center study was conducted at University Hospital Zurich, Switzerland, which is a 950-bed tertiary care teaching hospital that includes all medical specialties except pediatrics and orthopedics. The hospital has a dedicated infection prevention team and a goal-oriented infection prevention campaign that includes the surveillance of other frequent healthcare-associated infections, monitoring of corresponding prevention measures, and feedback of results to the department. Okay, for participants, all patients admitted to 6 medical and 3 surgical department with an NBHAP rate more than 50th percentile among all departments in 2017 will participate in the study. The study has three defined study period. Okay, first a baseline which was starting in January 2017 for all department, a 2-month implementation period during initial implementation activities commenced starting at the discretion of each department from March 2018 to October 2019, and the last period is intervention, which was original planned until October 2020, but unfortunately terminated prematurely on February 2020 due to COVID-19 pandemic. Okay, this study obtained ethics approval from the Ethics Committee of the Canton of Zurich, Switzerland, and the study is reported according to the standard for reporting implementation studies checklist. Okay, I would like to share about the step wedge design used in this study. Okay, step wedge design is a type of one-way crossover study in which clusters crossover from the control arm to the intervention arm at different time points. Gradual implementation of the intervention at the hospital. So all departments receive the intervention but are assigned to the timing of the intervention in a staggered form. This design allows for repeated measures at each department before and after the intervention period. So we will look at uh, we will look at the timeline of the study period. Okay, the period of baseline and intervention were different depending on the department. The baseline period ranged from 14 to 33 months, and the intervention period ranged from 3 to 22 months. As mentioned earlier, the implementation period was considered to start in each department once implementation activities commence, and it depended on the discretion of each department. Okay, now we will look at the intervention and
Faisal, oh
yes,
Faisal,
Prof. Yes,
I think two slide earlier, you put it in at the footnote, the lower part of the slide, the ethics approval.
yes.
I thought that ethics as evaluation was just done and it was exempted. There wasn't a proper evaluation, I think.
I see. Okay, okay, Prof.
Can you confirm that?
Okay.
I think because
Yes, that's the evaluation process.
evaluation and it was
Yeah.
said this study was exempted from,
Yes.
isn't it? So
Yes, yes.
it is not like primary study that the patients receive any interventions or invasive or treatments. It's
Mm-hmm.
actually implementations on our healthcare facility, and although the outcome is on the patient's outcomes, but
Mm-hmm.
the implementation, so-called interventions, were actually on the healthcare professionals. uh, I think later we may see what are the implementations strategies. So it was actually kind of a quality assurance, a quality improvement process. Like if most of us were working in KKM before, you know that this is like something, if you're thinking about medical audit, so it's something, the action part that you do some changes to your facility in order to improve the quality. So that's why I think the ethics exemptions was the one that is happening. It wasn't a proper, a full ethics evaluations and approval.
Okay.
Yeah.
Okay, right. Thank you, Prof. Okay, now we look at the intervention bundles for this study. So the NV-Hub bundle consists of 5 prevention measures based on the existing literature and anticipated feasibility and ease of implementation. For the prevention measures included oral care, dysphagia screening and management, mobilization, discontinuation of non-indicated proton pump inhibitors, and also respiratory therapy. Okay, for oral care, the department implementation teams should ensure patients receive mechanical oral care with or without pharmacological products once daily in all patients and 3 times daily in patients with swallowing difficulties. Okay, for dysphagia screening and management, a modified swallowing assessment (MSA) adapted from the standardized swallowing assessment was used to screen for dysphagia at the bedside. If MSA screening indicated risk of aspiration, the patient was referred to a facial oral tract therapist or a speech therapist for further evaluation and treatment. For mobilization, every patient without contraindication required mobilization at the bedside or out of the bed at least twice per day. Early post-operative mobilization was mandatory after surgery, and mobilization could either be executed by the patient or assisted by nurses or physiotherapists. Okay, proton pump inhibitors were restricted to an in-house indication list, and for the last intervention measure is respiratory therapy. So, responsible physician were advised to refer patients with the defined criteria to respiratory therapy. Okay, the
Uh,
implementation.
Perhaps not, Faisal. I think I would like to highlight the descriptions of the interventions.
Mm-hmm,
If you read also the supplements, you
mm-hmm,
can actually learn what does it mean by operationalize your variable. I
mm-hmm.
think they describe it very very clearly that exactly you know how to do on the field.
Yeah.
Yeah, so it is a very very good examples as how you want to operationalize your variable. Yeah, if you want to learn how is actually what it means by operationalizations of study variables. So this study they provided very very clear. Though you may not fully agree, but I think for feasibility they have to define it in that way so
Mm-hmm.
that the data are available for them to conduct the study.
Yeah.
Yeah.
Okay, the multifaceted implementation strategy was based on existing frameworks and designed to allow for local adaptation and ownership. Okay, department implementation teams included a nurse, a physician, and a physiotherapist. Okay, they were responsible for sustaining the core implementation strategies of education, skill training, infrastructure adaptation. For example, modifying the physical structure, equipment, record system, and policies to support the delivery of the intervention and adapting strategies to local needs. An institutional implementation team support department implementation teams in terms of establish and continuously adapt their action plans and implementation goals and provide educational and training materials. Applied formative approach with interim qualitative and quantitative result constantly used to enhance local implementation.
So, right, I think okay. I think you go on. I think it'll be clearer. Yeah.
Okay, so now we will look at the data collections and outcomes process. Okay, figure 1 shows the model and measures of type 2 hybrid trial. So as we can see here, the implementation phase started first, followed by the intervention phase. Data on implementation success and implementation determinants outcome measures were collected through longitudinal qualitative analysis using action plans, drop-in and focus group interviews. The, the implementation determinants, for example, the characteristic of the organization, departments and involved individual influence the selection and performance of implementation strategies of the department, resulting in varying levels of implementation success, which was reflected by the outcomes of the effectiveness trial. So the effectiveness trial was conducted using quasi-experimental before and after study to identify the NV Hub bundle adherence, the application rate of prevention measures, and ultimately the NV Hub incident rate. So the performance of implementation strategies of the department was not part of this report, so we have no data on that. Okay, so we will go detail about the data collection process later. Anything you want to add according this slide, Prof?
Okay, you see,
Mm.
so if you have read many papers, right, you immediately recognize that the design of this study is very unique. And if you remember the earlier slide show you that there'll be a baseline, because it's before and after, see, so they're comparing to before they do anything. So before the intervention, there's a interval of implementation. So implementation, this earlier slide show that they have to do some education, training, or structural adaptation. So that 2 months, the 9 wards, they will be doing all this all the intervention. So within 2 months, they have to complete educating their staff, train their staff. If needed, they have to adapt their wards, that kind of thing. So once that the two months period was up, so they will start the intervention. Meaning to say they change the way they do in the wards, whatever they were doing before. So once the implementations has been conducted, so they were expected to perform, to behave differently. So that will be the intervention period. Yeah. So it's and you if you are very RCT guy, then you'll be querying why this kind of a quasi experimental, how good would be the effectiveness? I always disagree of before and after study, but I'm not so sure whether there are other design, because if you still remember, this is step wage design.
Yeah.
A step wage design, so you can see out of the 9 wards,
Mm-hmm.
they'll be starting gradually. So later, I think when you read the analysis, because of this gradual participation of the wards, so I think, although it's not very clear, I think they quote the wards who implement or who intervene, the time when they have intervention, and there are wards that have not have intervention. So in the multi-variable regression, GLMM, so they have this variable with intervention and without intervention. Only then they can estimate the effectiveness of the intervention. Yeah.
Yeah.
So yeah, and they put in the baseline as one of the explanatory variable. So it's not as I understand it, it's not fully before and after, because they adjust for the baseline and they
Mm-hmm.
compare among the wards, because it's very gradual.
Yeah.
Some wards has started the intervention, some has not started, and so they compare the incidence of
And we have.
non-ventilated hospital-acquired pneumonia. So I'm not so sure whether when they say this before and after study, whether it's truly so or not, because they did actually compare among those wards that have started and those that have not started. Though this is not very clear, maybe later we'll hear the presentation, then maybe clear.
Okay. All right. Okay. So we proceed to the data collection and outcomes. All right. The study assessed five outcome measures, which included NV Hub incident rate, all-cause in-hospital mortality, process measures, implementation determinants, and implementation success. Okay. The primary outcome was the NV Hub incident rate per 1,000 patients day, aggregated by department and month. NV Hub cases were recorded retrospectively by a validated semi-automated surveillance system by the ECDPC. And the definition of pneumonia included radiological criteria, systemic signs such as fever, leukopenia or leukocytosis, pulmonary symptoms such as cough and sputum production, and also microbiological criteria, which is optional criteria. Okay, for the secondary outcome was all-cause in-hospital mortality, which was assessed on the basis of administrative data. The covariate case mix index or CMI is defined as mean case severity within a specific department and month. Okay, the third outcome measures was process measures, which was assessed using two ways assessment, which were application rate per 1,000 patient days, electronic medical record data aggregated by department and month, and second ways was adherence proportion, which was manual data extraction and patient interrogation in a convenient sample of 50 patients per department at baseline and 3 times during the intervention were used. Okay.
Are you all clear? Are you all clear? So you can see it's very, very rigorous. And I think the study was very much assisted or helped by having very good electronic medical records.
Mm-hmm.
You can see it's semi-automated lah, automated that kind of thing. So we are not informed of how good is the EMR data or that. But it seems like uh part of, I think the major part of the outcomes were able to be done because of EMR lah. And but they also recognize the limitation of that, and then they actually do this adherent proportion. So if you still remember the the ethics exemption, right? So this part actually involve patient, you know. However, to get the ethics exemption,
Yes.
um, I suppose is not something serious. No, it's just asking them whether the patients how much they perform the the implementation strategy, the five things, isn't it? Oral care, semua tu.
Yeah.
Yeah. So it's just a matter, I think, of interviewing lah. So
Mm-hmm.
interviewing is already a primary research lah. So I'm not sure why. Perhaps they have high trust level, so the ethics just exempt them. Okay.
Okay. For the implementation success outcome, the outcomes was described qualitatively in terms of four implementation outcomes. Okay, first acceptability. For example, how satisfied study participants are with the intervention. Appropriateness was assessed. The definition of appropriateness was the specific of the intervention and to what extent participants succeeded in adapting the intervention to meet the needs of their local context. Okay, fidelity means how closely participants succeed in implementing the core bundle components as described in the study protocol, and sustainability measure to what extent the intervention became institutionalized and anchored within ongoing operations. The implementation success was quantified as an exploratory outcome as implementation success scores. So the implementation determinants were established from the qualitative data. So data on implementation success and as well as implementation determinant outcomes measures were collected longitudinally through action plan interviews with department implementation teams, which were carried out once during baseline period and 3 times during the intervention period. Drop-in interviews with frontline staff, which was carried out once during baseline period and 3 times during the intervention period, and focus group with interprofessional frontline staff, uh, which were conducted at the end of the intervention period. Okay.
Um, just want to check in.
Yeah.
What do you think were the study participants in the implementation success here? About acceptability, appropriateness, fidelity, and sustainability. Sustainability. Who do you think were the study participants?
Healthcare providers.
Yes. Yeah, so it was not the patients, but it was the ward staff, all that, yeah, involved in the study. I mean, the 9 wards lah.
Yeah.
Yeah.
Okay, now let's move to statistical analysis, which is quite challenging for me to explain actually. Okay, we look at the sample size first. Okay, based on the binomial approximation of rates was used to calculate the sample size for this trial. So this sample size was calculated using Stata software. Okay, in 2017, the incidence of NV hub in the department included in the study was 153 events among a total of 13,591 patients. The researchers expected a reduction of the incidence due to the prevention bundle by 30% during the intervention phase. Okay, to show the difference between the two rates with a power of 80% at a significant levels of 5%, they estimated that a total of 250 events would be required for the study. So the calculation by using the Stata software, they concluded that a 1 year baseline with 153 events and a 1 year intervention period with 107 expected events would be sufficient for the study. Okay, the number of NV hub the number of NV hub cases and patient days per study period and department were descriptively report with unadjusted NV hub rate ratios (RRs) between the intervention and baseline period. And adjusted NV hub RR to quantify the effectiveness of the intervention in reducing the NV hub rate was estimated by a Poisson generalized estimating equation or GEE with log link with department as clusters. So the GEE was fitted to the monthly numbers of NV hub cases per department with the number of patient days in thousand as offset. Okay, a first order atau autoregressive correlation structure was used to account for the temporal correlation of NV hub rates within department. A time dependent department specific binary indicator for the intervention was used as an explanatory variable with baseline coded as 0, implementation as 0.5 and intervention as 1. Okay, department was added to adjust for differences in baseline and VHAB rates among department and sine cosine waves were added to adjust for seasonality over the monthly measurement. All costs in hospital mortality then was analysed accordingly. Comparison of study periods at the project level not included either in the main result due to the early determination of the study. Okay, for sensitivity analysis, they conduct three sensitivity analysis. First, to assess a potential regression to the mean effect, the GEE was repeated with the exclusion of data from 2017 because the study included department with relatively a high and history in 2017, and thus a potential reduction might be due to the regression to the mean. Second, to assess whether a change in the CMI of the patients might have confounded the NV hub bundle effect. The CMI or the case mix index available per department and month was added as an explanatory variable to the GEE. And third, to assess confounding by another or unexpected trend over time, the study mind was added as an explanatory variable to the GEE. Okay, to estimate the effectiveness of the intervention within individual department, Poisson generalized linear mixed effects model (GLMM) was fitted to the department level data and adjusted for seasonality. Pearson correlation coefficient between department-specific rate ratio estimates for the intervention effect and implementation success score in the corresponding department were then calculated. For comparison of prevention measure application rates between study periods, they use negative binomial GLMMs over distribution regarding Poisson on counts of each measure. Patient days in thousand used as offset. Okay, for comparison, the proportion of patients with adherence to prevention measures between the four visits, which were at baseline, at months of 1 to 2, 3 to 5, and 8 to 10 months of the intervention period. They used the binomial GEEs. To assess confounding by another trend over time, inclusion of the implementation success score and the interaction of the score with the intervention as additional term in the primary GEE model. Okay, for qualitative analysis, implementation success was primarily evaluated by coding the longitudinal qualitative data according to the four implementation outcomes, which were acceptability, appropriateness, fidelity, and sustainability. Assessment of implementation outcomes at 3 time points was carried out to identify leading and lagging indicators of implementation success. Okay, leading indicators are those that reflect the outcome of a change in practice early or even predict it. And lagging indicators reflect the delay between a change in practice and the observable outcome. Three researchers will review excerpt from interview transcript coded according to implementation outcomes to quantify implementation success for inclusion in the department level GEE model. So they were rated the degree of the four outcomes per department, professional group, and study period on a scale from 1, which was very poor, to 7, which considered exceptional. Okay, discrepancies among reviewers were discussed to reach a consensus. Okay, the ratings of the four outcomes and three professions, which physician, nurses, and physiotherapists, for average, resulting in one implementation success score per department and study period. So the implementation success score from the last assessment were used for comparison with the intervention effect. Okay, to analyze the effect of implementation determinants on implementation success, first, all the interview transcript and notes were coded deductively with the use of the theoretical domains framework as a coding scheme. And second, inductive thematic analysis were conducted to identify themes relevant to implementation within these domains. Analysis began at the department level to assess implementation success considering local barriers and facilitators. And then cross-case metrics were then used to explore trend across the department. So, Pro, what do you think about this analysis?
What do I think? I I would say it's very comprehensive. Some
Okay.
part of it very hard for me to comment because I think it's very advanced. It's just that one thing I'm not very sure why they use both GLMM and GEE.
Mm-hmm.
Why not just stick to GLMM? Because since GLMM is actually, I mean, more advanced than GEE, why should they want to use GEE? Since they know how to use GLMM, so
Mm-hmm.
that's why I'm not so sure because they don't explain as well. Yeah. So another question is that if you look at the past few slides North Faisal has presented,
Yes.
what do you think of the study design? You know, is it mixed method or is it multiple methods or is it both? And they apply everything. You know, it seems like you have to know everything in order to conduct this type of trial study.
Mm-hmm.
Yeah. So it involve quantitative, it involve process evaluation, it involve qualitative. Everything, you know. And you see the analysis, statistical analysis are also almost everything they have to know. I don't know how big is their team, you know. And so in order to do this, I think we really need to have a very good research capacity and environment. Is there questions there? How their evaluations, all profession with different background. Okay. So they actually, what I understood from the paper is that they actually interview. Uh, so if you, I think perhaps there was an earlier slide. They actually they have drop-in interview. They have a focus group, and they have frontliner, that kind of interview. Yeah. So yeah, yeah, action plans interview with the department implementation team. So and so they interview all these three professions, I think, not four, and they transcribe it, and there are two-way qualitative analysis. So if you go back to your slide on there's a theoretical domain framework. If you open out the supplement material, the yeah, so you can see all these domains, meaning to say they try to get from the qualitative data to fit in all these domain, whether the staff has knowledge, has skills, has all that. Because they have to have somewhere theoretical domain framework, they have the something for them to kind of assess. That's one thing. So and they are so comprehensive, and so they do a inductive analysis. They try to explore could it be anything else does not come into this domain. So they did both, and then I think they have how many of them? All seven. Uh, they score all of this from 1 to 7.
Yes.
Yeah. So then they average out all the sevens score, the three profession and the four outcomes, and then they give that average score for that department. Yeah, yeah. So in this method, it is like a mixed method. So they qualitatively they assess the outcomes here, four outcomes and three professions. Yeah. So the four outcomes are those acceptability, appropriateness, fidelity, and sustainability. And then the professions, the three professions, they assess them. They according to uh, their this theoretical domain lah, framework, and then they give how good they are, from 1 to 7, and then the few in I think there are a few in researcher there, and they compare first. They mean until the consensus, and then they average out for the department, and also per study period.
Yeah.
So very 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 rigorous. If you understand how they do, uh, you know, I just wonder, when or where the research center has that kind of capacity. You have to really, you know, gear up to do all these things. But whether they truly do so, then you have to believe them, isn't it? Or else have to go there and see, interrogate them. You just interrogate the patients, takut saya. It's not the interview, it's the interrogate. The 50 patients by random. Any potential bias? Uh, in what aspect? Can you elaborate? If you are talking about the qualitative research, so I mean they have their uh, qualitative strategy to improve credibility and transferability and quality of data lah. And if you are having some idea about qualitative research, the researcher, the interviewer themselves are part of the research. So they have to be very trained, well trained in order to interpret, the qualitative data, and whether you would want to bias, whether they can score their own stuff high, isn't it? Or good luck, kan? You can question that. But later you see the result, it wasn't so good, It was so difficult, actually. I so wonder, since the interventions implementing strategy are, are evidence based, why they don't want to do it? That come to my mind. Because later you see the result. In order to conclude the implementations. Yeah, okay. So they are actually implementation strategy, right? There are five, right? I think they you can assess whether there's any potential bias. I think what they did were actually they look at the outcome. They have outcomes, and then they go and check uh, not just the healthcare professionals, the staff in the ward. They also randomly pick 50 patients every ward to check their adherence, proportional adherence to the five strategy, isn't it? Yeah.
Yeah.
Yeah, so I think the way they conduct the interview, the qualitative part of it, and then the theoretical domain. If you can go to the slide again, Faisal, you can see there are so many domains,
Yeah.
all the way down. So they will check, let's say I check your knowledge, I check your skills about the implementations, the strategy, whether you. So there are examples there, knowledge, and then all the skills, all the way down to behavior, emotion, pun ada social influences, more all that, So the staff will be interviewed, and the researcher. I mean, I always think that as a if you are sound scientist, meaning you are not crazy, you don't fool yourself lah. Yeah, I don't. After all the works, I'm not going to fool myself and fool the world as how good my hospital is doing, lah, isn't it? The main point here is that you want to learn from it. I think there will be in the discussion point how they want to learn from this to upscale the implementation strategy in other hospitals. If they fool themselves, then it's not going to help anyone. Except if they want to achieve so-called KPI, lah, I am aware of that. All the KPI publications more too. But I don't think you have a sound mind researcher won't fool themselves and others. But you can see the rigorous of the things that they do. You can judge based on that, lah, because that's all we have, isn't it? And if they ask all this, and later you can see the result, it wasn't very positive anyway. Out of the nine department, you can wonder why they don't do it. Okay, thank you for your comments and questions.
Yes, Prof. In terms of bias, the study also highlighted the potential of desirability bias in the study because the study was conducted by members of the project team actually. So, but they trying to limit the desirability bias by doing the rigorous activity on qualitative research methods so that maybe overcome the bias. Mhm.
Mm,
Okay. Alright, so can we move to the result? Okay.
mm,
Alright. Okay. As overall, a total of 1,558 patients. Sorry. Okay. Okay. Table 1 shows the NB Hub cases, patient days and NB Hub incident rates per department and study period. A total of 451 cases of NB Hub occurred across 361,947 patient days between early January 2017 and the end of February 2020. Okay, 338 cases and 238.3 thousand patient days were recorded in the baseline period with the incident rate of 1.42 cases per 1,000 patient days, 19 cases and 19.12 thousand patient days in the implementation period with an incident rate of 0.99 and 94 cases and 104 and 5,000 patient days in the intervention period with an incident rate of 0.9. So we can see that the incident rate was reduced from baseline to the intervention.
Do you think it was more than 30% reduction?
Yeah, 31%.
Is it?
Yeah, if I'm not mistaken.
Is it a fair comparison? I mean, because patient days are different, The
Mm,
baseline there are so much, so many patient days, and the intervention they are just so because patient days incident rates is a kind of period, the quantity of observation.
mm-hmm.
The patient, the same patient may be admitted twice or maybe recovered and then got again the pneumonia. So they use this kind of patient days on the incident because it can recur. Yeah, patient don't just have one episode of pneumonia. So
Mm-hmm.
if I were to kind of standardize the baseline 238.33, right, uh, to 104.50, so that the baseline interventions are kind of comparable,
Yeah.
and I mean just a very gross calculations.
Mm-hmm.
So we have numbers of NVHAP cases is 119. I know over, if divided by half, divided by half would be 169. So 169 94 over 169. Yeah, I mean it's still more than 30%. Yeah, 45%. So
Mm-hmm.
it is, then it's actually powered. The study is powerful because
Mm-hmm.
they estimate the sample size based on at least a 30% reduction, isn't it?
Yeah.
But they have more than that.
Okay, the department adjusted and seasonality adjusted rate ratio between the intervention and baseline period was 0.96, corresponding to a 31% of reduction in the NV health incident rate. Okay. Okay. Project level result show a trend in the same direction without reaching statistical significance, and we have a rate ratio for 3-month intervention versus 40-month baseline period was 0.72. Okay. All seasonal effect with a peak in winter was detected. All sensitivity analysis showed a similar or even slightly stronger effect of the NV-Hub bundle. Rate ratio 0.68 when excluding the year 2017. Ratio 0.66 excluding CMI as an explanatory variable, and our rate ratio 0.63 when including the demand as an additional explanatory variable. Okay, we will look into the result of the secondary outcome. Okay, overall, a total of 1,558 patients died from any cause during the hospital stay, which 1,024 were recorded in the period, 83 in the implementation period, and 451 in the intervention period. Okay, on the basis of this number, the average mortality rate per 1,000 patient days was 4.3 during the baseline period, 4.34 during the implementation period, and 4.32 during the intervention period. The adjusted rate ratio for in hospital mortality was 0.92. Okay, results were similar in the sensitivity analysis, rate ratio 0.88 when excluding the year 2017, rate ratio 0.9 when including CMI as additional explanatory variable, and rate ratio 0.91 with the demand as an additional explanatory variable.
Do you can you go back? Yeah. Do you know why there isn't any significant difference in hospital mortality rate? No, there are already a reduction in acquired pneumonia. Why there isn't difference in mortality? Except the second one in your right side box sensitivity analysis, when they include the CMI, isn't it? Which
Yeah.
is an index of severity of the patients as a whole, the kind of case mix, isn't it?
Mm-hmm.
And why not the others sensitivity analysis and the adjusted rate ratio in the first place? Any idea?
I have no idea on that.
Anyone? It's a secondary outcome. The study is not powered for this. And
Yes.
mortality, I think, is not, they are not powered for it. Their sample size was not sufficient for them to see the conclusive result. If
Yeah.
should they power and plan the study to observe sufficient numbers of mortality, I think I mean by logical sense it will actually see a different. But,
Yes.
but this is a hypothesis. This is just until another study come along
Mm-hmm.
looking into this as primary outcome, then we will not know lah. But
Or maybe because the study was terminated prematurely, so
that
no
uh,
no data.
yeah, I mean that was for the intervention in the first place. They
Mm.
planned that for the primary outcome. Yeah.
Okay. All right. Okay, so we proceed with the process measures. Okay, figure 3 shows the two components of process measure, which were A and B. Okay, figure A shows the application rates of NV Hub bundle prevention measures per 1,000 patient days in each department level period. Okay, the box plot summarize all monthly measurements per study period. There were 213 monthly measurement for baseline, 18 for implementation, and 111 for intervention. Okay, figure 2 shows the adherence to NV Hub bundle prevention measures, which is indicated by the proportion of patients in a sample with adherence to prevention measures by visit at the baseline or after 1 to 2, 3 to 5, or 8 to 10 months of intervention. So let's zoom into the figure 3A, prevention measure application rate during the 3 study period. Okay, figure 3A shows the prevention measure application rate during the 3 study periods. Okay, from this, bedside dysphagia screening increased with the rate ratio 3.44, and prescription of proton pump inhibitors decreased in the intervention period as compared to the baseline period. And changes in oral care, mobilization, and physiotherapy, unfortunately, were not significant.
Yeah, you wonder why, isn't it?
Yeah.
But when you look at the department, there's a variation in their performance. I think department one very good. Department nine was very lousy. They never changed, even though they were told these are the 5 implementation study that can reduce non-ventilated ventilated hospital acquired pneumonia. So you wonder really the depart the what the department nine or what nine is they don't buy in the the idea.
Yeah.
That's why when you average out, but still the baseline dysphagia screening and proton pump inhibitor doses discontinuation were they actually change lah. They become they behave or they practice differently
Mhm.
after with this study.
Okay, for figure 3B, we can see that in line with the corresponding application rates as compared to the baseline, improvement were observed in the proportion of patients with adherence to a dysphagia screening and management with odds ratio 1.72, and discontinuation of non-indicated proton pump inhibitors with odds ratio 2.01. Oral care, mobilization, and respiratory therapy also did not change significantly in this period.
So these were from the patients, isn't it?
Yes.
The one was from the healthcare professional in the ward. This one, the 50 random patients,
Using convenience sample.
the same, the same strategy were, hmm, something like too consistent, between the two. I'm not sure whether this is a the same researcher effect or what. I hope not. Yeah, but this is the report. Only these two lah. I mean, become different with the implementations.
Okay. So for the qualitative analysis result, so the longitudinal the qualitative data were collected during 27 action plan interviews, 160 drop-in interviews, and 9 focus group interviews. Um, So the data inform formative adaptation of the implementation process, identification of relevant implementation determinants, and evaluation of implementation success. So this slide shows the some example of outcomes from the interviews. Okay, for implementation success outcome, overall implementation success varied across department and could be qualitatively explained by 4 inductively identified implementation determinants, which were core business alignment, perceived and rehab risk, physical proximity, and also key individual traits. Okay, as I have mentioned earlier, the implementation success was qualitatively described in terms of acceptability, appropriateness, fidelity, and sustainability. So, for acceptability of various elements of the intervention was high across departments and study periods among physiotherapists who described the NV Hub measures as being aligned with their core business. A low acceptability among all professional groups could be contributed by factors including perceived suboptimal timing of the project and the introduction of NV Hub measures alongside too many other activities as part of the
Mm,
hospital by infection prevention initiative.
mm,
Factors leading to high acceptability included perception that NV Hub measures led to observable improvement and high quality patient care, attractive implementation materials and meaningful events, and perception that the project required little additional effort. Okay, acceptability outcome were affected by the key individual traits, for example, the characteristic of people in participating department, including but not limited to local delegates, and the important facilitators were positive attitudes and charisma, intrinsic motivation, and the authority and latitude to make decisions. So in most department, acceptability among nurses increased throughout the project. Okay, for the appropriateness, finding also varied among nurses and physicians across department while remaining high among physiotherapists. The perception of appropriateness are largely driven by perceived and rehab risks, the extent to which a participant perceive their patients to be at risk of developing or having a high burden of NV harm, and also core business alignment. For example, how well the intervention aligned with existing departmental and professional activities and was perceived as being an integral part of their medical specialty. Okay, in department where appropriateness was initially perceived to be low, audit and feedbacks of NVHub rates and process indicated by the NVHub project team were often successful in improving motivation and changing valency among the local NVHub teams.
yeah, you remember the way they choose the five uh, wards were those that have the pneumonia rate more than, compared to the other wards, more
Yeah,
than 50% percentile, they can say.
percentile, yeah.
Yeah,
Mm-hmm.
so these were the nine so-called wards with a higher incidence of NVHAP
Yeah.
compared to their to their colleagues wards, other wards.
Mm-hmm.
Yeah.
Okay, for fidelity, study found that appropriateness and acceptability were leading indicators of implementation fidelity, which also found high among physiotherapists. Okay, factors leading to high fidelity included key individuals and positive attitudes in combination with organizational leverage to execute changes. This individual helps to overcome challenges which would have otherwise hindered the NB Hub implementation. Okay, in contrast, the fidelity was particularly low if the department implementation teams felt little responsibility for the project or if turnover affected local delegates themselves, which occurred rarely. And in general, fidelity was lowest among physicians, mainly due to perceived lack of time, resources, or low prioritization. And perceived lack of time was also pronounced among nurses for the mobilization measure.
Okay, do you understand by what it means by vitality?
Fidelity.
Yeah. What is this variable means?
So how well we adhere we implement the intervention.
Yeah, how closely
Yes.
the implementation strategy being applied according to their protocol.
Yeah.
Yeah, so how faithful are the applications according to the standard which is in the protocol.
Yeah.
So no surprise, isn't it, of the factors.
Yes.
If got no time, then they won't do it or they can't do it well.
Yes. Okay, for sustainability, which indicated by the extent of integration of environmental measures into routine, making them likely to extend beyond the project duration and assess in the implementation and intervention periods. Okay, higher sustainability was observed in professional groups and department with higher acceptability and appropriateness. Sustainability was substantial among nurses or some mostly in medical department whose core business aligned with the environmental measures. measures. Okay, sustainability was also high among physiotherapists who were already professionally attuned to the importance of any health prevention measures. Most physicians did not integrate process supporting the intervention into the established operation. However, the key individual traits were here counteracted. Some motivated and skilled physicians established sustained changes in electronic health record system and institutionalized training even despite low core business alignment. Okay, this figure show the result of quantified implementation outcomes over time per professional groups. We can see from the data from the nurses, physician, and also physiotherapists, the trend of the outcome implementation outcomes.
Yeah, this one that I alluded to lah. You see that they don't improve over time. Yeah,
Mhm.
though you think that they are in Switzerland, right? They high income, so they are very ethical, very high quality orientated people, right?
Yeah.
We don't see that in the patterns, and I think that also go to say that they are quite the researcher were quite, you know, neutral lah in the sense. Otherwise, they will just give all positive, isn't it? Inconsistency. Yeah, you depend on what you meant by inconsistency. So there's a variety lah, the variety in performance of the different groups of the wards departments, and that's what always being observed among the healthcare professionals, isn't it? And that's the point of having CPG lah, so called wanted to standardize how we behave. Hopefully there's a standard there, so or everyone follow the standard, so the variation will be kind of a lower, but somehow it did not happen, yeah, over there. But this is among the different professions lah, so they have their own reason uh for not like being consistently applying uh all the five or all their the x-axis here is about the four outcomes lah, implementation outcomes, yeah.
Mhm.
And it's over time lah. Baseline implementation and interventions. You would expect, the line is going upward, isn't it?
Yes.
Yeah. When the line is not upward, then you think they don't change lah over time. The implementation outcomes were not successful lah.
Okay. So we the implementation success score. Okay, implementation success score on a scale from 1, which was very poor, to 7, which was exceptional. At the end of the intervention, range from 3.9 to 6.5. Seasonality adjusted department specific and rehab incident rate ratio estimated by GLMM were between 0.77 and 0.49, corresponding to reduction of 23 to 51%. A higher implementation success score correlated with a lower and rehab incident rate ratio according to Pearson correlation. An increase of 1.0 in implementation success score was associated with a reduction in and rehab rate ratio by a factor of 0.66.
Hmm.
Mm-hmm.
I think there is a comment of questions there. How the treatment is delivered in different locations. Okay. This study design from the beginning is effectiveness implementations, and because it's implementations, and you know why they bundle, they have the multiple components implementation strategy, and they recognizing that the different department awards may have different priority or needs or unique conditions, so they kind of leave it to the ward to choose, which one do you think is most appropriate to your ward. So because this is kind of real world implementation, is always real world lah. So they leave it to the ward to choose which they think is their priority to implement. So there are five, right? Oral care, all that. So yeah, you're right. Then in that case, we can see there's a because is implementations science is not like in clinical trial that's very protocolized. It's very much like leave it to the site, which they think they want to prioritize. So then I think is by by nature or inherently we'll see the inconsistency, like as you observe. Yeah, I think you're right. Good observations. Yeah. So that's the so-called the principles of implementation science. They don't actually like force every words according to the protocol. They leave it to the wards to prioritize what they think is their needs, you know. So you can see there's a difference there. But I think the last slide that North Faisal present, I think was the researcher author's attempt to show that if you if you implement it, if your implementation success score is higher, then you have a lower incident rate of pneumonia. So they will actually give you the implement success score. So they kind of prove it to you lah. Now look, if you do more, then you get lower incidence. If you don't do, then you get lower. Yeah. So they even come to the last point, that increase of 1 point score. Remember, the score is given by the researcher, isn't it?
Yeah.
Yeah. So you can argue that it's very subjective, but you have to believe that they do it uh, in a scientific, robust, and neutral manner lah. Yeah. We can discuss that later on. Yeah.
Yeah.
So this
Okay.
they show it to you lah.
All right, this is the summary of the findings according to the five outcomes. So for the NV-hub incident rate, we can see that reduction of NV-hub incident rate during intervention as compared to baseline. All-cause in-hospital mortality, the adjusted rate ratio for in-hospital mortality was 0.92. Process measure for the application rates of NV-hub bundle prevention measures, as compared to the baseline, bedside dysphagia screening increased in the intervention period, and prescription of proton pump inhibitors decreased in the intervention period. So for the adherence to NV-hub bundle prevention measures, after 8 to 10 months of intervention, the proportion of patients with adherence to dysphagia screening and management are high, with odds ratio 1.72, and discontinuation of non-indicated proton pump inhibitors also revealed that the improvement with the odds ratio 2.01. Okay, for the implementation determinants, there are four here. Positive core business alignment, high perceived and hub risk, architectural characteristic promoting physical proximity of healthcare staff, and also favorable key individual traits. And for the implementation success score at the end of the intervention, quite high, range from 3.9 to 6.5, and implementation success score correlated with lower and hub rate ratios.
You know what? This summary is very, very clear. Very, very
Mm.
good summary. You can see implementations determinants will be the one I think they'll be using it. If you want to go to other hospital, they want to upskill it. They will really looking for how to align the implementation strategy to the core business of the wards. And then they want them to realize or aware that the NV HAP risk is high. Or if you want this to be successful, they have to go to those ward with a high pneumonia incidence lah. Those low one, unlikely they will bite in and they will going to implement it. And you see the proximity of healthcare staff. Does it mean the nursing counter is very close to the patients?
Yeah.
You understood it that way, isn't it? But how is that possible? I mean, are you
Yes.
going to put every nurse at at every cubicle like ICU pula?
Yes.
Yeah, okay.
Okay, so we proceed to the discussion part. The intervention led to a significant and clinically relevant reduction of the NV heart rate by 31%, but no statistically significant reduction in all-cause in-hospital mortality in the main model. Okay, department-specific reduction in NV heart rates are correlated with implementation success. Key of implementation success, our department positive core business alignment, high perceived and rehab risk, favorable key individual traits in local delegates and architectural characteristic, promoting interprofessional physical proximity. Okay, these findings are important because they underpin the preventability of NVHub while elucidating the implementation mechanism of a successful multifaceted intervention. Okay, as compared to literature, okay, there is a paucity of published evidence on the effect of prevention bundles on NV herb as well as on implementation strategy. Okay, but a multi-center study found a significant reduction in unadjusted and rehab incidence from 5.92 to 1.79 per 1,000 admission after implementing a bundle including mobilization, upright feeding, swallowing evaluation, sedation restriction, elevation of head of bed, oral care and tube care. Another study found that included patients on enteral feedings showed a 34% reduction in NVHAB incident when implementing a bundle including oral and nasal care, elevation of head of bed and daily review of tube fixation. Okay, another two study found that prevention bundles focusing on post-operative pneumonia um, reported reducing NVHAB incident by 40 to 80%. Okay, so now we will look into the strengths and uniqueness of the study. Okay, the study employ a well-established and rehab definition, including medical and surgical department, adjusting for seasonality, accounting for department as cluster in the analysis, and evaluating implementation success and determinants together with the effectiveness. Okay, the uniqueness the approach extend to a theoretically grounded implementation strategy based on department level ownership, education, training, and changing infrastructure, with ongoing local adaptation through the feedback of qualitative findings by the institution team. So the distinguishing implementation from the intervention effectiveness is crucial for the successful upscaling of an intervention. Okay, the process measures were assessed in two ways. The prevention measures application rate included all patients continuously but did not consider the requirement for each prevention measure per patient and day. And prevention measure adherence did not have that shortcoming but was restricted to a convenient sample of 50 patients per department at 4 study points. Okay, to maximize its practical value, the study was designed as type 2 hybrid trial, which tests the implementation process simultaneously with its effect. In the qualitative analysis, high acceptability and appropriateness of the intervention are the key or the leading factors for fidelity and sustainability in later study period, which could be further explained by the implementation determinants. Okay, the study also found that implementation success correlated with intervention effectiveness quantitatively, corroborating the qualitative findings and guiding the interpretation of varied intervention effectiveness between departments. So, anything to add, Prof, on this?
Yeah. Are you surprised with this kind of so-called points of strength and uniqueness? I thought they are quite common sense. Macam the last 2 points, right? High acceptability and appropriateness of the intervention are leading factors for fidelity and sustainability. Tu tak payah buat study pun, you ask a makcik pakcik dekat pasar malam pun tahu, isn't it?
Yeah. Mm-hmm.
Is there anything that we can valuable lessons here? Of course, beside all the result, all that, but all these like conclusions about very common sense to me,
Mm-hmm.
isn't it? Sometimes I'm very kind of afraid, this research enterprise and academia do a lot of things, very expensive research, and all the conclusion they get is just like, back to the, they climb very high, and then they just found that whatever conclusion or so-called wisdom, lessons are down in the hill, down at the hillside, at the foot of the hills. It's just very common sense. Do you need all this then to come to this?
Okay.
Mm.
All right. Okay. So we will the limitation of the study. Okay, the study has several limitations. Okay, first, it was a single center study and the results might not be directly applicable to other setting. Okay, second, the intervention period was planned to be 12 months, but the COVID-19 pandemic forced early termination, which affected the statistical solidity. The implementation start date was at the discretion of each department as a pragmatic solution respecting their preparedness and capacity. The researchers do not believe that the differences in start date challenge the findings as the sensitivity analysis excluded a temporal trend and a regression to the mean of NV hub incidents. Okay, fourth, NV-Hub surveillance and analysis of qualitative result were conducted by members of the project team, as I mentioned earlier. So they limit the desirability bias by doing the rigorous qualitative research method to maintain emphatic neutrality during data collection and analysis. Okay, some components of the NV-Hub definition used for surveillance, for example, radiological criteria, um, subjective, leave room for subjective interpretation. So limiting the outcome measure to microbiology confirm, and we have might have partially overcome this limitation, but would have required a prohibitively larger sample size. Okay, six, process measures were inherently difficult to assess, so that they counterbalance this challenge by applying two evaluation methods, but due to the limitations of both methods, improved adherence might have been missed, especially in oral care and mobilization. Okay, length of hospital stay and outcome measure mentioned in the study protocol could not be assessed because of unavailability of the required data. Okay, the bundle design precluded the possibility of examining the effect of single bundle elements. Moreover, the choice of bundle elements had to be pragmatic. Last but not least, due to the rarity of NV-Hub, the study was underpowered to detect an effect of the bundle
Mm.
on all-cause mortality in the main model. So the study found a statistically significant reduction in only one sensitivity analysis that included the case mix index
Mm.
and explanatory
I
fact.
noted of that.
Mm-hmm. Yeah, that's all the limitation for the study.
Okay, do you think this study was required? You know that the evidence-based implementing strategy, oral care lah, dysphagia screening lah, mobilization lah, they are all evidence-based.
Yeah.
Then why is the busyness of doing a study on that? Just implement them lah.
Mm-hmm.
Or was it not very sure? They were actually arguing that individually the strategy was proven, but
Mm-hmm.
as a whole, they wasn't very sure lah, isn't it?
Yes.
Do you agree with that?
Mungkin because previously the bundles of prevention measures were not being proved before, I
Mm.
think, but
Yeah,
the single measure ada.
yeah. So that was the
Yeah.
argument,
Hmm.
and then I think this study, the main takeaway will be implementation finding, implementation determinants, implementations, success rate, all that. I think they have them in mind. They want to implement it uh, all over hospital in Switzerland, but they wasn't very sure how to do it.
Mm-hmm.
Whether the way they think they are going to do it will be successful or not.
Yeah.
So that's why it become a type 2 hybrid lah.
Mm-hmm.
If you are more unsure or you want to give your attention to the effectiveness of the bundle, then it's a type 1. Just
Yeah.
a little bit of implementation somewhere in the clinical trial, so-called the type 3 clinical trials.
Mm-hmm.
If you are what you have or the implement strategy interventions was very proven,
Mm-hmm.
like all the bundle has a very good strong evidence, then you would want to give attention to implementations, so that become the type 3.
Yeah.
But I think most of the time the numbers of type 2 are more because
Mm-hmm.
it kind of the balance between the two.
Yes.
Yeah.
Simultaneously produce a result for the both yeah, effectiveness and also implementation.
Yeah,
Mm.
I think it also gives you a very good idea, isn't it? No,
Yeah.
Faisal.
Yeah.
We're looking at the translation research, assessing the translation research landscape in Malaysia.
Yes.
So it actually give a very good idea how can we assess whether there was a translation, meaning
Yes.
whether the implementation was done, isn't it? So
Yeah.
now we have that very clearly, but not sure whether this was also the data are clear out there lah, which may
Yes.
not be very clear out there as well.
We hope that in the type 2 hybrid trial were more conducted in Malaysia so that I can use the data.
Maybe we will want to encourage this type of study design, isn't it?
Yes, that's
Don't
what.
don't just purely on the clinical trials without implementation part of it. Because
Mm-hmm.
if you think it's so important that you want to do the interventions, so you can incorporate the implementation elements into your into your proposed study, so they
Yeah.
can have, at the same time you get the data for implementations, how to implement it successfully. But I think as Mohammed Noor Firdaus observed, this is much more complex compared to just purely clinical trial or purely implementation science study. Oh, you have one another slide. Okay.
Okay. This one, the last slide actually, for conclusion and relevance. So there are seven conclusion here. Okay, and VHAP is a frequent healthcare associated infection affecting a broad patient population. Okay, second, the prevention bundle led to a reduction of NVHAP. A combination of prevention measures effectively reduced the NVHAP incident rate. Third, intervention effectiveness correlated with successful implementation of the NVHAP bundle. Implementation success was associated with the preventive effect. The implementation strategy was described as well as contextual, individual, and organizational factors associated with implementation success. Knowledge of the determinants of implementation success might help in upscaling and rehab prevention. Knowledge of these factors could help promote and rehab prevention in other healthcare settings. And last, importantly, the distinctive description of implementation and intervention effectiveness can be especially helpful in the future upscaling of and rehab prevention initiatives.
Yeah.
Okay, so okay, so we will appraise this study. Okay, for this study, I'm using mixed method appraisal tool MMAT because the study for me use the mixed method design. Is it appropriate, Prof?
In some part of it, I think it usually involve multiple. People may not be very clear with the terms mixed method and the multiple methods. Yeah, I
Yes.
think it is a mixed method and but also multiple methods. It's here and there, everything, almost like maybe not everything like economy is not in, SEM not in lah, but almost
Mm-hmm.
like the common skills of conducting quality and quantity research are required, in order to complete this kind of study.
Yeah.
Yeah.
So, okay. So, based on the evaluation using this tool, so we will evaluate according to four items, screening questions for all types. Are there clear research question? Yes. Do the collected data allow to address the research questions? Okay, for me, yes. Okay, for the qualitative part, is the qualitative approach appropriate to answer the research question? Okay, yes. Are the qualitative data collection methods adequate to address the research question? Yes. Are the findings adequately derived from the data? For me, yes. Is the interpretation of results sufficiently substantiated by data? Yes. And is there coherence between qualitative data source collection, analysis, and interpretation? I'm not sure about this, but I think yes.
Mm.
Okay, so for the quantitative non-randomized part, are the participants representative of the target population? Yes. Measurements appropriate regarding both the outcome and intervention? Yes. Okay, are these complete outcome data? I think no because
No, yeah,
because the data for the long hospital stay,
yeah,
yeah.
wasn't there.
Mm-hmm. The co-founders accounted for the design and analysis? Yes. Okay, for the last part, for the mixed method, is there an adequate rationale for using a mixed method design to address the research question? For me, yes.
Yeah.
Different components of the study effectively integrated to answer the research question? Yes. Are the outputs of the integration of qualitative and quantitative components adequately interpreted? Yes. Divergence and inconsistency between quantitative and qualitative result adequately addressed? I'm not sure about this, Prof.
Mm,
But I
mm.
yes.
It
But
wasn't very obvious. Even the
mm,
5.3 also wasn't very obvious. I think this is very applicable to mixed method. I think the one that's mixed is the one that when they trying to do the determinants, the implementation determinants and success
mm,
score, and
mm,
they go and qualitatively interview and then they give a score. So they quantify their so-called qualitative data according to uh, the four implementation success outcome. So
Mm-hmm.
only that part was mixed method, I think. The
Okay.
rest will be quanti and then quali.
All right.
Yeah.
Okay. All right. Okay. So that's all for me, Prof.
Right. Thank you very much. I just think it's very, very interesting, but unfortunately, there are so few participants to this MJH. But anyway, we got a very good recording. We may actually share. And in the coming newsletter, I think we will shall share more about this kind of study design. I'll try to find a few more articles or to share about it. I think it's very, very good. But I think the capacity of the researcher also has to be prepared, ready for this kind of study design. Otherwise, yeah, very difficult. Okay, so thank you again, no Faiza, for very, very interesting, uh, yeah, very interesting presentations and very, very, very interesting paper as well. So approach is very, very good. I agree with you. Yeah, Fridaus. So get yourself trained and be prepared. Well-round researcher will know to do all this. But I think we still need a good biostatistician in. You need that kind of expertise to handle that kind of data.